Welcome to our CTSNet Giants in Cardiothoracic Surgery series. My name is Jessica Luke, and I am resident editor of CTSNet and cardiovascular surgery resident from the University of British Columbia. I am delighted to be here with the honor of introducing Dr. Lars Svensson. Dr. Svensson is chairman of the Cleveland Clinic's Heart and Vascular Institute, which has ranked #1 in cardiology and heart surgery for the 26th year in a row by the U.S. News and World Report. He is a world authority in aortic surgery and renowned for his work in advancing research on brain, spinal cord, and kidney protection during major cardiac and aortic surgery, as well as simplifying and modifying the elephant trunk procedure, the modified David's reimplantation procedure, as well as development of the minimally invasive J incision for performing keyhole surgical techniques. He is principal investigator in numerous clinical research trials and is author of over 400 scientific publications. And as if all those accomplishments are not enough, he is also author of the textbook of cardiovascular and vascular disease. Dr. Svensson chaired the American Association for Thoracic Surgery Guidelines Committee and has chaired multi-specialty guidelines writing committees for aortic valve surgery and treatment of thoracic aortic disease. Dr. Svensson, thank you so much for being here today and accepting our invitation.
Well, thank you very much, Jessica. It's my pleasure to be talking to you. As you know, I was reluctant to do this. I don't consider myself a giant in cardiac or cardiothoracic surgery. As the old John Newton saying goes, I've been fortunate to, in a sense, ridden on the shoulders of great giants and looked over their shoulders when they operated, and I learned from them. And so I'm a reflection of the great people I had the opportunity to work with.
Well, thank you so much for joining us today. And you are a giant in cardiothoracic surgery in my eyes and the eyes of many others.
Well, thank you.
So without further ado, perhaps we can start with what inspired you to become a cardiothoracic surgeon?
Well, it's an interesting question, and I'm sure most people don't particularly find this sort of thing interesting, but I wanted to do engineering and become a mechanical engineer, and I now live vicariously through my son, who's a mechanical and aerospace engineer, and actually doing his PhD in aerospace. And so I was committed to mechanical engineering, and indeed at Treverton College, where I was, I never looked or studied biology, botany, zoology, and went straight into medical school, never having done that. But what happened was we were on vacation, and my father was listening to the news in the morning, and he said, I want you to listen to the news at lunchtime with me. So I said, okay, fine. He wouldn't tell me what it was. And that was when we were in December on vacation. And that was when Chris Barnard did the first heart transplant. And so that triggered a bit of interest in me. It sounded like it was fascinating, probably involved some engineering and, maybe a heart lung machine and so on. As you probably know, Chris Barnard together with Vincent Gott were early pioneers in the heart lung machine, and that was research being done in Lillehei's lab. And so that stoked my interest. I had been exposed to a lot of healthcare because I'd grown up on a hospital in a very rural part of South Africa. In fact, rural, underestimated. It was a very wild part of South Africa. It was completely undeveloped, a lot of wild animals and that sort of thing. And so I had piqued my interest, and then I felt I had a calling to do medicine, and so I went into medical school, and that's how I ended up. And I wanted to do heart transplant surgery. I did some animal research on that, in particular baboons, and then when Chris Barnard got rheumatoid arthritis, I said I had a job with him, in fact, and I was going to work for him. I said, he stopped operating and left cardiac surgery. I said, if you don't mind, I'm going to then pursue further training overseas. And that's how I ended up at the Cleveland Clinic and then Houston.
That's amazing, Dr. Svensson. And can you tell us about your greatest mentors as well?
Sure. I was fortunate to have some really great people who mentored me. Obviously, my parents, who instilled in me, purpose in life and what the priorities were. And when I was at Trevorton College, the school or college, what we call principal, what you'd probably say a president here, got me involved in a lot of things. And I captained various rugby and cricket teams, athletics, and despite the way I look like now, once upon a time I could run a pretty good 880 and 800 meters. And he also pushed me academically and got me involved with running the sort of state science foundation and organizing meetings. And that was the first meeting I really organized, and I've always enjoyed organizing meetings. And now for Cleveland Clinic, I oversee our CME program for HVTI, and we usually do about 20 CME meetings a year. So he gave me a lot of responsibility, but it was always there to help me when I needed help. And that was, I learned a tremendous amount, both from rugby and team playing, and also from him in leadership. Later, when I was doing my PhD, Ron Hinder was a fantastic supervisor for my PhD and also during my general surgery training and vascular surgery training. And then when I came to the Cleveland Clinic, I was very fortunate to have some fantastic, outstanding mentors, Fred Loop, Toby Costro, Bruce Lytle, Paul Taylor, people like that, Leonard Golding, tremendous people, and I kept contact with them and they were just wonderful. Then I went down to Houston and there spent time with predominantly in aortic surgery with Stanley Crawford, who really was the father of many aspects of aortic surgery. Got to know Denton Cooley, and then Michael DeBakey was a very important sponsor for me. Whenever I needed money for a research project, I'd go in and say, Dr. DeBakey, this is what I did the last year, this is what I'm planning and would like to do next. And he would say, okay, how much money do you need? And off I went and did my research. So he was very helpful from that. And he and Stanley Crawford helped me get my green card because I came on a J1 visa in the United States. And they put me in charge of cardiothoracic surgery at the VA in Houston. And at the same time, I was able to work at Methodist and be involved, obviously, with Baylor. And developed great friendships with Joe Caselli and Hazem Safi and a lot of trainees who went through that time. So I was very fortunate to have very strong mentors. And over time, I also developed, fortunately, through them, very good friendships with leaders around the country. Craig Miller in Stanford, Hartzell Schaff at Mayo, Larry Cohn at Brigham and Women's, and very influential people like that who have helped me in my career.
It's amazing. I think that we all truly stand on the shoulders of giants, and it's amazing to hear from you as a legend in cardiothoracic surgery and all the other giants that you have learned from and who have mentored you. It's truly a full circle and goes from one step to the next and to the future generations.
Yeah, it's very important, and it's very important to mentor our future generations below, that follow us. And that's something that's a responsibility for leadership.
Thank you so much, Dr. Svensson, for sharing your mentors with us. And can you tell us about what inspired you to simplify the elephant trunk procedure, replacing the total aorta in a single operation, the modified David's reimplantation, as well as the J incision? I know that there's a lot of procedures in there that I have just listed, but I'm always very fascinated with how leaders in cardiothoracic surgery go about innovating in the process of doing so, and what those experiences are like.
Well, Ron Hinder, my PhD advisor, gave me very good advice. I had done a master's on wound infections, and he said, "Why don't you do that as a PhD?" I said, "I don't want to be seen as a PhD world expert on, wound infections. It was the last thing I wanted." And so he said, "Well, go and find a problem and do some reading around it, and see if there's an opportunity to do research around it." And so paraplegia after thoracoabdominal, and I started off with reviewing traumatic rupture of the aorta, was a problem. And so I then did the research around that and developed some options, including intrathecal papavering, which we continue to use for thoracoabdominals, and we've shown that reduced the risk of paralysis by half. And so I've always thought that that basic mechanism is very integral, I think, to us as humans. If you think about the Khoisan Bushmen, which I always have had an interest in with my background in South Africa, being taught anthropology when I was in medical school, you basically go and study the situation and try and figure out what you're going to do about fixing it or addressing it, and then you take action, and then you debrief. And so when it came to the elephant trunk procedure, Hans Borst had written about it, but it was clear a lot of patients were dying after the first stage operation, or they were dying during the operation from the aorta tearing. And so one day I was scrubbed with Toby Cosgrove, and I said to him, it's always a bit difficult to sew in the gap in the distal aorta. What about if we invert the graft and stuff it down the descending aorta and do an anastomosis that way? He said, that's kind of interesting. I think what I'm going to do is try and invert it, but keep the graft in the field. And so that's what we did. I remember the patient very well. She was a young African-American woman, and she did fine. She was in ICU a couple of weeks, but she did fine. And then when I moved to Houston, I said the same to Stanley Crawford, and he said, well, let's try that. So he then put it in the descending aorta. And by that stage in Houston, we had quite a lot of data on early and late outcomes of the elephant trunk procedures. And there was the risk of bleeding and tearing of the aorta, and also interval rupture before second stage. And we largely eliminated that once we started putting extra plegited sutures of that anastomosis, putting it down in the descending aorta, and then using the ritoplatin for arterial inflow, which most people don't know. Stanley Crawford did the first LVAD operation for Michael DeBakey, and he used the subclavian artery for inflow, and I believe that was in 1967. And I'd learned about that when I was with Stanley Crawford, and so I started using the subclavian artery for arterial inflow during arch surgery. And in our prospective randomized trial, we reduced the risk of stroke to 0.8% and mortality rate 0.8%. And if I remember correctly, about 2/3 of those patients, this was for total arches, had elephant trunk procedures. So that was the elephant trunk procedure. But then when we started stenting the second stage, Roy Greenberg said to me, I'm having problems both with the elephant trunk being kinked, which wasn't an issue for open second stage, and also finding it during stenting the second stage. And so I work quite a lot with Roy Greenberg, and what we did was I put some clips on the end of the elephant trunk and a piece of pacing wire, and then we could hook that during the second stage to complete the operation. As far as our modification of the David reimplantation operation, I went to visit Tyra David, who trained here at the Cleveland Clinic many years ago. Must have been around about probably 96, 97 or so, when he was first starting out. And he was doing the measurements and so on. I thought, I'm not sure about this. And after I'd done a few, I realized that positioning the commissures was critical, and you had to eyeball it. I also thought that if we put pledgets in the left ventricular outflow tract, we would reduce the risk of some of the fistulae and so on that have been seen with the David reimplantation operation. And then I thought that if we reduce the annulus to a more normal size, particularly in these Marfan patients, we probably would have better durability. And so we used a hay gauze based on body surface area apart from pledges to tie down. And we're now up to about 1,100, 1,150 reimplantation operations. And in the elective patients, we had a mortality rate of 0.12%. And we're just analyzing our data on 1,005 patients. And our durability is 97% at 10 years. And in the 214 patients with connective tissue disorders, mainly Marfan's, we actually haven't had a 30-day death with the operation. And the interesting thing is the durability is about the same. You asked about the J incision. I had watched Manuel Antunes do redos without opening the whole chest, just splitting the upper chest. And that was kind of interesting. And then Toby Cosgrove invited me to watch him do lateral thoracotomy, minimally invasive operations, aortic valves. And flying back to Boston, I had a patient with Marfan's who needed a composite valve root and mitral valve. And I thought, I need a bit more exposure and control of the ascending aorta. And so what I did was then the J incision from the sternal notch into the third intercostal space. Now we usually go into the fourth intercostal space. And I did a trans-aortic valve, mitral valve replacement. In those days with mechanical valves, because this was a long time ago, must have been 95, 94, 95, somewhere around there. And then put in a composite valve graft, and that became the J incision. And Toby adopted that for a lot of his mitral valves and aortic valves, because the paramedian incision was a bit more difficult, and the right lateral thoracotomy patients were developing lung hernias. And so that's what happened. As far as the first total aorta replacement, the part of the reason was that a lot of our patients who had elephant trunk procedures weren't coming back for their second operations for various reasons, partly because some of them died in the interval. In one of our papers, as I recall, 12% died in the interval. And then some didn't want to come back. And I had a patient who had a 16 centimeter proximal descending aorta, ascending aorta was 6 centimeters, infrarenal was 6 centimeters, he had aortic valve regurgitation. And I thought, the only way we're going to be able to do this is do a J incision for the ascending arch part, and then do a thoracoabdominal incision for the rest. And so for that patient, we then replaced the entire aorta. Our brain circa rest time was 10 minutes. The total body circa rest time, as I recall, was about an hour. And I kept the patient hypothermic while I did everything. So the ascending aorta, we did the arch first, and then through the thoracoabdominal incision, the rest. And he lived many years. I don't know if he's still alive, probably not, but I would get a letter every now and again from him. And the only medication he was on was aspirin once a day. So those are kind of some of the operations I've been involved with.
That's amazing, Dr. Svensson. It's so inspiring. And you are chairman of the Cleveland Clinic. Would you have some advice on how to become a successful leader?
Boy, that's a great question and a topic I like to talk about. And I run a leadership course here for HVTI. There is a YouTube sort of summary. It's a 10-minute summary of some of the things I shared with our team, because we were about to start up a new leadership course and then COVID hit. And this is a summary of an hour-long talk on what I think is important for leadership, so people can look it up. I think the key things are early in life, one has to establish one's purpose, what you want to do with your life, what's important in your life, emotional intelligence, what your vision is for your life. You need to decide what you want to do with your life. And I think it's only fair for people who are involved in your life, whether it's a spouse or whatever, that they know which direction you're going to take, because cardiothoracic surgery is a very big commitment, and it imposes a lot on the time of people. The key other things are integrity and reliability. Then I think the way I look at it when I'm looking for new recruits is, do they have a lot of energy? Are they able to energize other people? And from a leadership point of view, can they carry out a plan, a strategy, in other words, execute on that and make sure they've got the right tactics, and then make difficult decisions. EDGE, as the 4 E's that Jack Welch came up with. He certainly hasn't always been considered the greatest leaders, but I think there's a lot to learn from him. I would add that in medicine, we have to have leaders who display empathy, educate younger people for the next generation, a certain level of, as Bruce Lightfoot would say, gravitas, but elan, to make it an E, innovation. So that's not an E, but innovation is obviously not, but E, innovation. And then I think it's very important for a leader to be a cheerleader, whether that's for success or for sorrow in your group and your team. And that's unfortunately part of what we need to do with leadership. There was a very good paper a few years ago in the Harvard Business Review looking at some 2,700 CEOs and what made them successful. And they looked obviously at those who weren't successful. But the leaders who were successful, they were reliable. They executed decisions quickly, so they were quick decision makers. They were looking for high impact for their companies, and they were innovators. Now, if you think about those, that's what cardiothoracic surgeons do. I mean, we make decisions with incomplete information on a regular basis in the operating room. So that comes naturally as a leadership skill, I think, for a lot of cardiac surgeons, and we have to be very reliable. A cardiothoracic surgeon cannot go in and have an off day. Well, today I didn't throw the ball as a quarterback so well. I had a couple of interceptions and we lost the game. It's just not acceptable for a cardiothoracic surgeon. You've got to be at the top of your game all the time. And so that's another thing about leadership as cardiothoracic surgeons, being reliable. We, I think, tend as a group to be great innovators, and we do work for impact on patients' lives, and think those are critical aspects. We could talk a lot of other things, starting from when I was at Treverton College. I've always had an interest in the issue of leadership and how you succeed, what results in failure. And I have my own working definition that I hang my hat on. It's not something that you're going to see in a business book on leadership, but what I would summarize it is that great leadership is the ability to foresee the future challenges and opportunities, develop a reliable strategy, and then through the tactics of influence, integrity, trust, motivation, lead your team to a higher goal that has moral impact. And in the video that I was referring to, I sort of work backwards. You have to have that higher goal in leadership. Otherwise, as far as I'm concerned, it's not going to be great leadership. So I have in my corridor outside here photographs and paintings that emphasize that, and particularly that of Lincoln and Martin Luther King, but I've also got other leaders, pictures in the corridor, Churchill. Now, they were great leaders and they had very high moral values that they were aiming for. But one cannot get away from the fact that they've also been leaders who have influenced their countries, and we want to look at, say, Russia, China, Germany, etc. But they were great leaders for their people, but they didn't have that moral value, and I think that's where one separates the great leaders from the greatest leaders from the moral point of view. And in medicine, we have the moral value of taking care of our patients. You might call it the North Star. I refer to it as a lodestone with my Viking background. So that's how lodestone, from where the sun, in a sense, guides us. Goals, metrics. You cannot produce high quality care if you're not looking at the metrics and adjusting and discussing that. And then the other aspects I mentioned, the personal aspects of leadership, like influence, integrity, trust, being able to motivate people. And part of leadership is developing strategy for your team and trying to guess what's going to happen. And obviously now during COVID, that has upset a lot of our plans and the way we look at medicine. But that's part of leadership. You have to deal with those aspects. The other thing I would say is when it comes to motivating people and keeping them engaged, you have to deal with people on a personal level. And so that means that they have to foresee personal growth for themselves. You have to allow them a certain amount of autonomy, especially for physicians and cardiothoracic surgeons who are very intelligent, very skilled. And they have to master their craft. I find that as young cardiothoracic surgeons master their craft, learn judgment, which is often something they don't learn very well during residency, that leads to a much happier person. And then there are other aspects, personal relationships, family, friends, having interests other than medicine, but also diversifying your professional career, and that includes being a great surgeon and clinical care, but also being involved in education and research. So that one of the things that I think has been a very important issue to deal with in healthcare, modern healthcare, is the electronic medical record. And I've seen a lot of dissatisfaction, particularly for the older physicians, in getting used to electronic medical records. And so efficiency in taking care of patients is a very important part of that. And I touched on relationships and how important they are. I think particularly as medicine continues to evolve, we're going to have less and less resources, and it's going to become more and more of a calling. But people are going to have the resilience to deal with the challenge of the future. Fortunately, in cardiothoracic surgery, we're in a very exciting field. It's very gratifying. It's a great privilege for us to not only save lives, but also improve the quality of people's lives, and also give them a much longer chance of survival and spending time with their families. And so it's a wonderful speciality to be in. And I've always loved the fact that I went into cardiothoracic surgery and didn't become an engineer, but I lived vicariously through my son's education and training.
Thank you so much for all the advice and insight, Dr. Svensson. Very inspiring. Basically, the whole is greater than the sum of the parts, and being a good leader depends on you being a great person, but also supporting and nurturing the team and building the team around you to achieve a unified goal.
Sure.
And in addition to your leadership roles, you also maintain a very clinically active practice, and at one time doing over 680 operations in a year. How do you go about achieving that, specifically for advice for those who are surgeon leaders and also trying to maintain a clinical practice?
Well, it involves a great team around you. I mean, when I was that busy, I had fantastic support, and the Cleveland Clinic is set up so that surgeons can be very busy and have the support around you to manage a lot of the aspects. For example, gathering the tests together, making it efficient practice. I mentioned that earlier. And so that was fantastic. We have the setup at the Cleveland Clinic to do that, and our leaders of the past made sure that that situation was set up, that it was very efficient, and we were able to concentrate on spending our time in the operating room and taking great care of patients. And the infrastructure that they set up was just wonderful for being able to do
that. And on a personal note, I hear that you have the world's 19th largest lion skull in your collection. Can you tell me more about how that came about?
Yeah, so I have a small collection, not that many, I don't know, half a dozen different types of skulls, plastic skulls of, for example, polar bears. I've been up to Canada and Churchill and photographed polar bears up there and seen the skulls on the tundra from polar bears that have died. I saw, for example, the American lion skulls at La Brea Tar Pits in Los Angeles, and they're about a quarter the size bigger than the African lions. And so I also have a tiger skull, which interesting is not quite as big as the lion skulls. Anyway, and I love photographing the big cats, and in fact, one of my former trainees gave me a wonderful trip, and I also spoke in India, but I managed to visit both Corbett and Ranthambore and photograph tigers in both places. So the big cats have always been a fascination for me, and that started when I was growing up, where I used to ride my horse as a kid and ride around the African savanna and grass fields with my dog at the heel, was where the largest lion ever killed was shot. It weighed 690 pounds. Now, the reason why it's not recorded as where it was shot, which is in a very wild place in Africa, and at that time it was very wild. It was 20 years before I was born, obviously, but it was south of the Kruger Park. And the reason why it's listed in the Guinness Book of Records as Hector Strait is because that's where there was a railway, a refueling station for steam engines to get water and coal. And so they had a big weighing machine there. So they took the lion when they realized it was so big, it'd been killing a lot of the local cattle, and took it there. And they weighed it at this town. Well, it's not a town. As I said, it was a place where they refuel called Hectorspate. And as a kid, that's where I used to catch the steam engine train to get to school. Take 2 nights and a day uh, to get to school. And so it was weighed there. And I've chatted to the family, and the guy who actually shot it was a man called Anderson, who prospected for gold in that area. But he also had a rifle, so he was called on to deal with problem animals. And when I was growing up, there was a so-called motel. Uh, it it was actually a shanty building, more of a bar, but there was a couple of rooms in the back for the people to sleep over if they had a problem at this train station, that sort of thing. And Anderson shot a very big buffalo in that area that was chasing people and trying to kill people too. And this buffalo has got wide horns, about 50 inches wide. And there's now a proper sort of hotel there. And if you want good luck, you've got to kiss the buffalo on the nose, and that brings good luck. So I went aside there, but so I've always had an interest in the big cats, and I love photographing them and watching them, although my favorite is the leopard. And for many years, I supported research on lions in Zimbabwe. The population of lions has shrunk tremendously over the last few decades with the loss of environment, growth of populations. And the population is probably only about 35,000 left now in the wild. And a friend of mine actually was involved in helping to restore the lion population in India. And so I'd been sponsoring lion research in Zimbabwe. The research was made famous when Cecil the lion was killed, because he was one of the lions in the research project. And so I helped with the sponsorship of that research, lion collars, GPS, etc. And I helped 3 guys do their doctorates at Oxford. One of them was actually a Rhodes Scholar too. And so I'd been supporting the research, and they said one day, you've helped us out. Is there anything we can do for you? So I said, I've always had an interest in lions, and if you have a lion skull, I'd love to have one of the lion skulls. And so it turned out one of the 2 lions in one of our research projects that I sponsored that were collared, one of them got killed when 3 other lions took over the pride. And so they gave me that lion skull, and I hadn't thought much about it. And then one day I decided to look it up and measure it the way they're supposed to do it, Roland Ward measurements, and turned out it was the 19th largest recorded skull. So it joined my collection of skulls. I have a baboon skull, 2 baboon skulls too, from my research time. And so that's the story of my lion skull. And my son has actually went out 2 years ago to continue the research, to work with the researchers. And they do some fascinating stuff. They have accelerometers, they have acoustic recorders, apart from GPS and radio collars on these lines. So they've learned a tremendous amount of stuff, and the PhD doctorate stuff that's come out of that has been fascinating. And my son in particular has worked on brown hyenas, which are very rare, but happen to be a large population of them in this area in Zimbabwe. And so he's enjoyed that. And, they've got a paper they're working together with Oxford University on brown hyenas. So it's been fascinating to watch that side of things.
I see a trend with large cats here.
Yeah, Well, one night my son was researching, and they weren't seeing any lions or brown hyenas. They were waiting for them to come in, and they play a recording and bring in animals that way. So they decided to break out their sandwiches and have a sandwich. They had the lights off and they're eating their sandwiches. My son said, I'm feeling a bit uneasy. Let's just turn on the lights and see if there's anything around. And there was a big male lion at their door, and they had a broken window in their Land Rover. So they kind of got a bit of a fright, but he didn't harm them. So if you're good to lions, they're good back to you.
That's amazing. And thank you so much for sharing that story. And finishing off, Dr. Svensson, what do you see as the future of cardiac surgery?
That's a very good question. And we could talk quite a lot about that. I don't think COVID is going to have a very big residual effect on cardiothoracic surgery. We had a update on COVID and heart and vascular disease this morning, and it's available on the, or will be shortly on the internet. The first one we did under a year ago, and I don't think that's going to have a big effect. We'll probably see some increase in heart failure and some patients needing lung transplants. We've done 2 physicians actually have had lung transplants. So we may see some residual disease from that. And that's obviously high on the ticket at the moment, but we cannot get away from the fact that in 2019, according to an article in JACC, if anybody wants to look it up, 25 million people died from heart disease and stroke. 19 million were heart disease. And there's an epidemic of coronary artery disease now occurring in third world countries. Whereas previously, when I was doing cardiology, there was a belief that in Africa, coronary artery disease didn't occur among the African populations. And then we started seeing it more and more. Now it's an epidemic, and there are many reasons for that: Western diet, hypertension, diabetes, the so-called P25 particles, etc. So around the world, coronary artery disease is going to grow. It's beginning to uptick in the United States again, and the data I'm referring to shows that the global load of cardiovascular disease. And we have seen an uptick in our coronary artery bypass surgery volume again. We foresee increasing peripheral vascular disease. The one area that I put together a graph some 5 years ago, what's going to happen in the next 10 years, and it's holding pretty true. There's going to be a big increase in heart failure patients, and obviously heart failure devices to manage those patients, and obviously we have a limitation in heart transplant organs, and we are going to see more EP type procedures. So this is sort of long-term residual effects of atherosclerotic coronary artery disease, but also adult congenital heart disease. So those areas I foresee growth. My own impression, and backed up by this paper that I'm referring to that I just looked at, the rate of aortic aneurysm and aortic disease seems to be fairly stable. There's no major increase in that. So that probably is not going to increase. The other thing is that in patients over the age of 75, 12% have valvular heart disease. And so we're going to see more valvular heart disease. But at the same time, we're also seeing a lot more percutaneous procedures, and I see that not slowing down. In other words, we're going to see more of less invasive procedures being done, whether that's percutaneous, endovascular, TAVR, obviously, non-invasive operations for the heart, robotic mitrals is something that we do a lot of, and the results of that are very good. We actually haven't had a death from a mitral valve repair for 6 years now, touch wood. And the results of cardiovascular disease management have become a lot better even in the last 5 years. I mean, the mortality rates for heart operations have continued to go down despite the increasing complexity of heart disease, reoperations, multiple valve plus CABG procedures. So there are a few trends that I foresee, both driven by disease prevalence and also by more and more innovative procedures being developed in managing cardiovascular disease.
Well, thank you so much, Dr. Svensson, and certainly for myself and on behalf of CTSNet, you have made amazing contributions for the cardiovascular surgical community and patients worldwide. I thank you very much for joining us today. It has been such an honor and pleasure to feature you in our series of Giants in Cardiothoracic Surgery.
Thank you very much, Jessica. I enjoyed chatting with you, and I'm just a product of being fortunate by providence of having great mentors, and I have a wonderful team I work with. It would never succeed without the great team of cardiologists, vascular surgeons, and cardiothoracic surgeons, and many other people, our administrators, our research team. We're one big happy family, and we work together. So thank you very much, and best wishes for you for the new year and your future training.